I want to thank Karen Grimsich especially, who was the moderator. Could we give them a bigger round of applause? And all of our panelists, thank you. We're going to move on to the second panel now, so I'll ask our panelists, and welcome Scott, I'm glad you're here. Panelists and moderator, take the stage. Thank you, Monique. Our next panel, Systems Transformation in Alameda County. And I first want to just briefly introduce our moderator for this panel, Dr. Monique Parrish. She's the Director of Life Course Strategies. And you'll see, check out her bio in the program. You'll learn more about Monique. I will say that she just completed a gap analysis for Santa Clara County that looks at many of the same components of this system that we're talking about here today. So I'm really glad that Monique is here to moderate our panel. And
get going.
Take it away. Yeah. The clickies, you can all advance your own slides with the clickies.
Okay, this is open. Hi, everybody. Thank you so much, Wendy. I would like to concur with the former comment, I think it was by Jamie, about the genius of Wendy and her vision for this day. And it's because we started with Dr. Kushel, who introduced us, I think, in a really lovely way to just people, just the faces of people, the needs of people, and that was such a wonderful reminder as we think about the complexity of integration and coordination and financing and systems that we start with people. And then the previous panel was truly equally remarkable and wonderful because those individuals who are representing community-based organizations and health systems highlighted these integration efforts and the importance of looking at people with all of their needs. And so really honoring that whole person care initiative. This panel is going to take us up a little bit in terms of altitude, and we're going to look at some larger initiatives. The whole person care pilot, we're going to also look at a health homes model pilot, and then we're going to talk about really the Alameda health system kind of then sort of moving down a little bit and looking at, again, how integration and opportunities for these larger initiatives, which we'll introduce in a moment, really are affected at the local level for all of us here, whether you are a provider or a consumer or whether you are an advocate. And then we are going to conclude with Randy, who has the wonderful and rather daunting job of pulling it all together and giving us sort of a roadmap for how we integrate. But the best part is after this panel, when you all get to meet in your individual table groups and have these discussions as you're really synthesizing and thinking and addressing issues from your own expertise. So with that, let me first introduce our panel. And we have Nancy Halloran here, who is the Director of Policy for Alameda Healthcare Services Agency. And next to her, we have Scott Coffin, who is the Chief Executive Officer of Alameda Alliance. And then we have Dr. Claudia Landau, who is the Chief of Geriatrics and Palliative Medicine over at Highland Hospital. And next to her is Randy Morris, who is the Director of Alameda County Aging and Adult Services. Before we go ahead and just introduce these initiatives and sort of go down the road here, I'd like to have just a few oversight slides just to frame this for everybody. Okay. So again, notwithstanding any changes that may be happening with our healthcare system or even the Affordable Care Act, we are very fortunate that with the 1115 waiver, and this is part of the Social Security Act, which actually allows states, very quickly, for those of you maybe less familiar, allows states to waive certain Medicaid or Medi-Cal program requirements and to obtain federal matching funds to really invest in innovative healthcare delivery. So we have two initiatives that are related to 1115, and for the time being, we anticipate that will be steady as they go. And the first is the Whole Person Care Pilot, and next to that is Prime. We're not going to address Prime, which is unique to public hospitals. It's the public hospital redesign and incentives in Medi-Cal. But we are going to talk a little bit about the Whole Person Care Pilot. And then we're also going to talk about health homes. The health homes for complex patients is part of Section 2703 of the Affordable Care Act. And the state of California had applied for this through the Centers for Medicare and Medicaid, and it has been approved, and we're sort of marching forward. For the purposes of this panel today, we're going to just look, especially with the whole person care pilot and the health home, where are sort of these intersecting common denominators? Again, as things are bubbling up, and all of you may be thinking about this either in your work lives or personal lives, this will provide some background for that. So let's go to the next slide. Just again, one more sort of visual. I love the idea of Venn diagrams, those intersecting diagrams, and really, as people, we're all intersecting in many of our component parts, right? Our personal and professional lives and our families and so forth. So here we have the whole person care pilot on the left, and we have the health homes on the right. They are both addressing in different forms, looking at coordination of services, whether health and behavioral, as well as perhaps in the health home, some supplemental services. So we have this esteemed group here, so I'm going to stop here, and I'm going to introduce Nancy Halloran, and she will provide a summary of the whole person care pilot that Alameda County was just awarded.
Should I go over there? Or? Okay.
Sure.
If that's working, then I'll do that.
And I think there's a working
my
mic.
neck.
Okay,
Which
right.
is always important. Is this okay? All right, great. So I wanted to say thank you so much. It's really exciting to be here. One of the things that's really exciting about Alameda County Care Connect, which is the name of our whole person care pilot, is, for me personally, is I am learning so much. I'm learning about all of these different parts of the system that I had never been exposed to because, you know, we work in silos. So, so thank you so much. I was thinking about being here and the fact that this is an older adults conference, and I wanted to actually just start by kind of dedicating my day or my talk to my mother-in-law, who is 91, and this just a few months ago, with just super strong, powerful, tiny little frail woman who was a survivor of the Holocaust and was walking across the street a few months ago and got hit by a car. I know. Broke multiple bones. This woman has an amazing spirit. And thank God also had insurance and support services and a family. And even so, it was a just painful journey. Dealing with the SNF and the hospital and insurance. And, you know, so just want to say, even though I don't work directly, I'm not a provider of services, and I don't work directly with seniors, I have a very strong and very vivid experience of the needs right now. And I'm happy to say that she is walking. She walks a third of a mile a day up and down the hallways of her apartment, and she's got nowhere to go but up. So, so here's to Elspeth. Okay, I wanted to also say on behalf of the county that we are very, very invested in preparing for the silver tsunami, as they say. And we at Healthcare Services have been partnering with social services on the countywide plan for seniors. The Board of Supervisors recently dedicated some additional Measure A dollars to expanding services, and we are very excited about the developing partnership with Alameda Health System and the Alliance around these services. So I think as a system, we are very, very aware of how much we need to do better, and we are on it. Okay, what is whole person care? So this is a part of the waiver that Monique just mentioned. It was a competitive application, and the county is the lead. We have to match dollars one for one to get the dollars. So we were in a very strong position because Alameda County has dedicated a lot of dollars really to, we've been moving toward whole person care anyway. We really don't consider whole person care just a project, but more the way we want to do things. So that's been something we've been moving toward, and so when this opportunity arose, we had county match dollars that we were able to build on. So a lot of programs that you may work with now are part of our match, and the purpose of Alameda County Care Connect is going to be to weave the pieces together. And many of the things that I heard people talking about earlier about the problems, I hope we will have the opportunity through whole person care to make some difference on a lot of those problems. It's an amazing opportunity. So we got $28 million of new money per year for 5 years, so that's $140 million, which is very exciting, and the main purpose of it is to build infrastructure. So one thing that's really important about it is, and especially now, since there's so much uncertainty in our future as far as Medicaid goes, is that it's about building infrastructure. We have this money for 5 years, and then it goes away. So everything that we do is about investing in something that's going to have lasting impact. And our partners are working together with us to make that a reality. And just to note, it is specifically for Medi-Cal, and we can only serve, the services that are part of the program are only for people who are on Medi-Cal. But the infrastructure that we build is ultimately going to serve our system and all of the highly vulnerable people that we care for. So here is basically the organizing principle about AC Care Connect is we want to help people move from a place of crisis, whether it's homelessness, frequent hospitalizations, emergency departments, and also substance use, criminal justice involvement, to a place of their optimal wellness by supporting them to access the kinds of services that produce more stability, such as supportive housing, primary care, substance use treatment, and we are very dedicated to the concept that includes bringing people's own communities and own families and own strengths to bear. Our safety net services are fantastic and essential, but cannot do it all for anybody and shouldn't. So as we develop these things, we want to make sure that we are also building in how do we support families and communities. The population that we're serving is, for this 5-year period, people who are homeless and people who are, it's an unfortunate acronym that we are going to try to avoid actually using, high utilizers of multiple systems. But basically, if people are involved in the crisis system, to be able to move them toward, they will have access to this program in the short term. And what we call the care coordination program, which means that if you are part of a system that's already doing care management or care coordination for someone who is in facing highly complex conditions, those people will be able to opt in to enroll and be part of our data sharing system and our care coordination system that we're going to develop. Am I doing okay on time?
Got about 45 minutes, right?
Okay, so kind of going quickly through these parts, almost half of the dollars are for housing services and infrastructure. Now, we can't build housing with this money, we can't pay rent with this money, but we are partnering with the housing community and the homeless community to add the supportive services that will enable people to take advantage of things like the county bond that just passed and other housing opportunities. So, what will be different as a result of this? So, on the left here is the AC Care Connect components. So, we are going to create a system of care coordination. That means we're going to work together with providers, with you all and others to develop a common set of tools for care coordination. Some understanding about what are we what are the basic elements of data that we are all going to share, or how are we going to triage people from into one program or another, working together to create a common set of tools and also a common culture, a common language, understand each other's systems, and create, with consent, a community health record, which basically means a small amount of curated data, not the whole health record, a small amount of data that people will be able to share that includes who's helping to care for a particular person and how can we work together with them, and identifying who the lead care coordinator is and being able to communicate about that. So the patient will experience a consistent front door experience and be able to navigate the system better. Our housing solutions for health includes 1,000 additional supportive housing slots to match 1,000 existing unsupported housing opportunities, but also building housing opportunities, helping people transition from a crisis place to a stable housing situation, and facilitating transitions between the different parts of the system, including substance use and the courts, et cetera. And then a backbone organization that's going to make it possible to implement all of this. So what will be different for providers? There's an opportunity that I think we'll have a chance to talk about more later, to participate as a community-based care management entity. We will be asking providers to help us design this care coordination system. There will be easier communication, which is like one of the problems I heard you, Karen's panel, talk about a lot. We will be putting into place a consent system for the clients that want to participate. And we will have, this bullet, broaden our view of who our colleagues are. That means those of us who come from the healthcare system are going to think of you all as our colleagues in a much deeper way than has currently been the case. So what have we done? We are taking what we, from the medical side, have typically been a medical clinic, a hospital, maybe if we're lucky, the mental health and substance use systems, and we are adding, collaborating in this extremely chaotic manner, I don't need to tell you, and bringing it to a much more organized and smooth way of working together, and adding in the social determinants of health and the housing into our system. There are systems of care, like functional systems of care. If we want to think about kind of how do we approach this, we're trying to weave together many different systems that exist. They're overlapping systems. Some of them are functional, like primary care, mental health. Some of them are population-based, like the older adults system of care. You all have relationships, conversations, language that you know. So one of the things that we are going to be doing with our backbone organization is addressing the human infrastructure. So people learning each other's organizational cultures, building relationships between housers and healers together in the same room, and thus learning to problem solve together, but also understanding the barriers that each of us face, which are different. Let's see, and then the populations I put up here, older adults and reentry, but that's just ultimately, it should include the whole lifespan. We'll be talking ultimately about, youth, children. It should ultimately serve that whole community. Am I almost out of time?
You're just about, yes.
Okay, so I'm actually going to skip the next slide because we can talk more about it at the table. I'm going to come to an end and say, this is my motto. The best time to plant a tree is 20 years ago. The second best time is today, and that's what we're doing. We're putting together the system that we really envision and that we need for our future.
Thank you. Thank you, Nancy. So Scott, you're welcome to stand, or you're welcome to... Okay, great. So we have Scott Coffin from Alameda Alliance, the Chief Executive Officer, and he will address the Health Home Pilot.
Great. Well, thank you. Good morning, and thanks to Wendy for the invitation. I don't know if I let her finish her sentence when she asked if I could come in to share with you some of the things we're doing here at the Alliance, but I was here last year and it was an honor to talk with all of you, and I'm glad to see the room is even more full than last time, so that's a good sign. So Nancy's done a great job of giving you an overview of whole person care. We all know it's impossible to treat the partial person, so it's all about whole person care. Oh, thank you. Is that better? Okay. In my presentation, I have a few facts of the county, which many of you probably know or are part of and aware. So I'm not going to spend too much time here reciting the challenges as well as the opportunities. But we often reflect back at the Alliance and look at our community as a whole and try and come up with some solutions. And one of those solutions is tying into and getting behind whole person care, because it's a very meaningful initiative, and it is time to do it. And so we're excited about that. But when we look at the landscape and we talk with our providers, and I'm out every week, it seems like I hear a lot of common themes, a lot of common stories about the access to care and the timeliness of that access and the changes that are going on in Medi-Cal as a whole, as a state program, and really what it means to us here in Alameda County, which is really important. So some notes about the Alliance. Very proud to serve at the Alliance. Great company, great organization. We've been a part of the safety net for 20 years plus, another 20 plus years to go to reach the mission. We're a public initiative health plan. We're here to serve the community. And we're based in Alameda. If you haven't been over to our office, y'all are welcome to come over. We have almost 300 employees, and we're facing, again, many of the same challenges that everyone's facing. We have 267,000 members, each with unique needs. And what we're doing is transforming the health plan into a managed care health plan. Corin mentioned it best, I think, about the face-to-face case management, the personal interaction that's needed. That's what really ties together, I think, the model of care in a more meaningful model. And we're looking at models that are in both California as well as outside of California, but really what it comes down to is, what are we doing here in Alameda County? So our membership is divided out all throughout the county. In 9 cities, 91% of our membership resides and lives. 39% right here in Oakland. You can see the other circles there. The reason I show this to you is because at the Alliance, we're taking a different approach. Over the past couple of years, we've been really focusing in on knowing our members, knowing the people, our patients, ultimately, knowing where they access service, knowing the challenges. One of them is knowing where they live, just to start off with the essentials of connecting our members to the primary care that they need in a timely way, specialty care, hospitals. All of that pulls together. So this is an idea here of the county. The Alliance only serves Alameda County residents. This is a breakdown of our provider network as it stands today. Tomorrow, it's going to be a different number. A year from now, the numbers are going to be even greater, because the benefits are changing. The programs, we're adding more programs. We have to build networks. And we need more capacity. So these numbers are probably as good as of 11:15 today, and because each day they fluctuate. Another important aspect to look at is the access to the care within our network, and that's something that's our job and part of our responsibility in managed care, is to make sure that the timeliness of that care occurs when needed. So the Health Home Pilot, why I'm here. This is exciting. If any of you have read Section 2703, it's fairly light reading. Section 2703 talks about the Health Home Program, and it has a lot of parallels to whole person care, and that's essentially why we're so interested, I think, as a county and as a community in this, the opportunity. But one of the challenges that came up a while back was the Alameda County was not scheduled to go live on Health Home until 2018 or possibly even 2019. And you know how programs do, they move, and typically the dates move out. So kind of like a child that wants to open up that gift, we jumped ahead at the Alliance and wanted to start it sooner. And so we funded, as part of this year's budget, a seed capital to start the program, to get the concept out there, to start working with providers in our community to expand out our networks. And really, it's focused in on helping our highest utilizing members. And it's all about quality. Cost is on the backside. Quality is the most important piece here. We have 4% of our members at the Alliance that equate to about 80% of the medical costs. But when you start to look inside of that, just like we looked at the map with where our members live, we started looking deeper into why are they accessing these services and when? What are the conditions that each of our members are going through, working with our providers to come up with some solutions around pulling together case management in a new and better way, but taking what's already there. It's not about necessarily creating anything new. We want to take what's already there. We're also, because of the timing with whole person care, want to make sure that we connect in is that we're not creating any new technologies. We're going to leverage resources that we have because, as Nancy mentioned, in whole person care, there's an initial investment in that infrastructure. So we don't want to duplicate either. My challenge is I have 4% of my members, which is about 10,000 people that have significant needs right now. And so the opportunity is to start and create these linkages here in the community. So offering a range of case management services, intensive case management, all the way down to the basic navigation. That would be in scope. The care model is really built on a population-focused design. Again, looking at the data, looking at our members as people, and coming up with some solutions. Leveraging, the federal framework on, 2703, when you look at the essence of health home, we're using all of those components, but we're bringing it down to Alameda County level, what's going on right here with our residents. So we're going to be launching this pilot. We're going to cover both ends of the county, ends as in north and south. We are using data analytics extensively. We're working on the future on predictive analysis, but really what we're trying to understand is what's happening right now. The predictive analysis is coming though, and we have already expanded that into our current practices, but we need to look at it more. The big piece though is identifying the gaps in care. The larger piece is treating that gap. And that's where we need you in this room to be part of what we're doing at the Alliance. The coordination to treat and avoid the unnecessary usage at the hospitals. We hear the problems and we understand, but this is the time to try some things out through new ways of thinking on how we connect our providers together with the health plan. Interdisciplinary care teams, it's been talked about a lot, and it's really an important thing. But again, the pilot's going to focus on linking our community resources, our people together, our caregivers together on a smaller scale. And then we're going to learn some lessons that are going to help us to expand that on a broader scale later. Because Health Home as a program is likely going to be coming to us. We just don't know exactly when. But we know we need the essential tools of it, and I think through whole person care, aligning these two programs together is going to mean, I think, a lot for everybody in Alameda County. We're a strong partner in whole person care. We've been a big supporter in just the formation, the idea, and getting behind Alameda County Healthcare Services Agency from day one about the opportunities. We're getting ready this month to launch a request for information. And it's going to be somewhat of it is a formal process, but it's a less rigid process around what we're normally used to in proposal writing. But we want to find out who's interested in the community. And so there's going to be some public announcement releases going out in the papers. We're going to be sending out invitations. I'm casting an invitation right now here to you all. We want you to be part. So we're going to put out the RFI this month. We're going to be doing evaluations and hopefully starting this off. If we can get everything going in the first quarter of next year, which is right around the corner. So we're very excited about this. To reiterate, the Alliance has committed $500,000 for this pilot, and we're going to be carrying it into the next fiscal year, which we're mid-fiscal year, so it comes up on July 1, and we will be hopefully continuing this program as we go into the next year. And so I'll stop there.
Can I just interrupt you for 1 second? So again, I think it's, if I just borrow you for a quick second. So the whole person care pilot is this big county-wide effort. And then of course the health homes pilot is generated from the Alameda Alliance, Medi-Cal Managed Care organization. But again, there's intersections. I want to, as we continue to delve into this, want to make sure, so one has a big sort of umbrella and infrastructure development, and this is a specific focused effort, but coordinated with whole person care. So
Yes,
just want to make
absolutely.
sure.
Yeah.
Okay, fantastic.
Yeah, and we have partners, many here in the room, Lifelong, CHCN, folks that we're already working with, and this is about, expanding how we're working today. Alameda County Healthcare Services Agency with the County Behavioral Health, Public
Right.
Health.
Okay.
It's just continuing that, but on a smaller scale.
Exactly.
Yeah.
Great. Well,
Okay.
thank you so
All right.
much.
Thank
Scott.
you.
Okay, great. All right. Dr. Landau, you would like to stay there? Okay, I'm going to pass the baton to Dr. Landau, and she'll share about her programs.
I'm so honored to be here in a room of such creative, committed, and thoughtful elder advocates. Thank you so much, Wendy, for inviting me. And forgive the pun, but I'm going old school, and there are handouts on the tables of most of what I'm going to say. Wendy wanted me to talk about what Alameda Health Services is presently doing in terms of geriatric and palliative care and our vision for the future. And as I talk about where we envision us going, I'm so excited by what I've heard. I already want to meet with people because there's so many places to interface. So the hallmark of geriatric elder care really is, in my opinion, and in the discipline, communication and integration. And by definition, it is whole person care. And what a geriatrician cares about is everything, is how somebody lives, how their health is, how their emotional health is, how their family support is, where they're living, how they walk, how they can take care of themselves, dress themselves. Are they happy? Are they finding meaning in life? And as a discipline, we believe in that kind of analysis and evaluation. So we are completely aligned with the concept of whole person care. Interestingly, there are only 7,000 geriatricians in the country. And so one of our missions at Alameda Health Services is to educate people, and we train residents. So that's a big part of our goal when we think about the programs we're going to develop. Presently, all our residents rotate through a geriatric experience, and we have created an intensive experience for primary care doctors, because primary care doctors are going to have to learn a lot more geriatrics. There will not be enough geriatricians to manage this silver tsunami that was, we all knew about, but we didn't really prepare for it. What we have presently is a geriatric primary care clinic. We have three geriatricians in our system. We have 2 locations of our geriatric primary care clinic. And we try to utilize these for the most complicated, frail elders, or people just don't understand how to take care of and improve their outcome. The other thing Alameda Health System has is a tremendous, as you all know, we're one of the most culturally diverse counties in the country. And so not only do we have the issue of taking care of complicated elders, but they're from many different cultures, many different languages, which also adds a whole overlay to the care that we have to be sensitive to. So we are trying to teach our residents how to do that. We also have a consultative geriatric clinic, which is where people can refer their patients to get help. So it's mostly my clinic. I evaluate people and give people advice and hopefully educate how they can take care of other patients in the future. Now, we do the same thing for the inpatient. We have an inpatient geriatric consult service so that while patients are hospitalized, there are a lot of conditions that people don't pay attention to. And one of the things that I was struck by in the other presentations is that when people are in the hospital and they're old, they often get confused just by being sick. And delirium, which is the term, in the hospital is very prevalent in elders. The older you are, the more likely you are. If you have any cognitive impairment or multiple medical problems, which 50% of elders have 2 or more and 80% have at least 1, you're going to be you're not going to be functioning at your maximum capacity. And it can take up to 3 months for that to return to normal. So navigating post-hospital systems after you're sick is even harder than before, and we don't always attend to that. So as geriatricians, we want to teach the hospitalists as well as the residents how to manage that in the hospital and prepare good discharge planning. We also have palliative care interdisciplinary hospital team, and we are now developing, which I'll mention in the future, an outpatient palliative care clinic. Another thing that we have is, I'm sure many people here are familiar with how significant mobility and falls are to elders. 50% of people over 65 are likely to fall. 33% over 65 and 50 over 80. But if you have 4 risk factors, it goes up to 75. And the risk factors are multiple medications, being a woman, being over 80, and so that even many people over 65 have a huge risk of falling. And falling and the sequelae is the 5th leading cause of death in elders. So we have developed a fall prevention program that has 3 parts. One, we screen everybody in our clinic for falls. It's a very easy thing to do. And then once you screen them at risk, what do? So we have a fall prevention clinic, which is interdisciplinary, that is both educational, rehab screening, and pharmacy review. And right now it's sort of as needed doctor. Hopefully we'll build that into it. We're hoping to partner more with the community because obviously exercise and involvement and walking and doing dancing it helps prevent falls. We also have a fall prevention program in the hospital, but we're trying to conceptualize it more as mobility and walking rather than preventing falls, because one of the things that happens in the hospital for older people is actually they get functionally worse, so that they walk in the hospital and they leave having to go to a nursing home. So we're trying to prevent that, and ultimately really putting the resources into that will be very cost effective. We have a neurocognitive clinic which evaluates cognitive loss. We have neuropsych testing. We have audiology services. We do have skilled nursing, which has some respite beds, particularly for families who have people with cognitive impairment. And we also have something that really is tremendously important in taking care of people, which is in-person interpretation. Because if you can't hear and you process slower and you're trying to evaluate subtle problems that affect elders, it's very hard to do over telephone. So, how much time do I?
You have about 5 minutes. About 5 minutes.
Okay. So, while all these clinics are fabulous, they're not integrated at present. So one of the things we really recognize is we need to do a better job at integrating our care for elders, and that's obviously the theme, and in almost what everybody's saying, as well as communicate. Because communication, I believe, particularly with older people, because there's a lot of nuance and subtlety in taking care of people well and empowering them, which is what we want to do. You need to communicate. And part of that, what we hope to do is educate, because we want to make sure that all our primary care providers have access to geriatric knowledge, education, and expertise. So someone mentioned, I think it was Dr. Kushel, but I think others, that geriatrics as a medical discipline is more interested in syndromes that are often overlooked by traditional internal medicine and family practice, yet have incredible impact on people's lives. And let me just mention what they are. That are often underdiagnosed, but have a tremendous, if you take care of them, people's quality of life improve dramatically. Incontinence, falls and mobility, skin, pressure ulcers, delirium, all aspects of functional decline, depression and anxiety, cognitive impairment and insomnia, as well as osteoporosis. Now, they don't fit classic diagnostic models that doctors are taught, nor do elders read physiology textbooks. So the way their bodies present, because they've had all different levels of stress, they have multiple medical problems, they have multiple medications, can be subtle. And somebody can just fall and have a pneumonia and not have a cough. So we want to do something where we really can offer evaluative services and educational services. So what we conceptualized was a system, and this we do not have, this is what we're working on, and we also want to work with all of you in the room to succeed at doing this, is perhaps right now we're conceptualizing an Institute on Aging, which the name could change tomorrow, as a hub in our organization for evaluative services that would be available and consultative services to everyone in the community. And it would have three parts. It would be medical, it would be geriatric, which is not just medical, it's a biopsychosocial evaluation, but also have a health education unit and a care management unit to be able to implement and what am I trying to say? Share all of these with everyone in the community. This would be education not of just clinicians, but what people mention, families need to know. When do I call the doctor? When is somebody sick? How can I make sure, what do I need to do to help our elders stay well and thriving? So that is part of what we conceptualize. We also would like to have what's called an acute care for elder unit in the hospital. Those are designed to maximize function and minimize bad outcomes, and they're very successful. We do already have our geriatric and palliative consult service. Where communication is a key is that we want our care management unit to help the communication between all of these facets. We'd like to have home visits or partner with people who are doing home visits so we can share communication. And then we would see all of these resources as available to all the community-based clinics. I'd love to talk to Alameda Alliance about how we can integrate with their care management and have an integrated system for our patients. So that's our vision. We're working on it. Our first goal, and we have a business model, is for this consultative evaluation Institute on Aging.
Wow, amazing. Well, thank you very much, Dr. Landau. So we're gonna turn to Randy Morris, the Director of Alameda County Aging and Adult Services, and sort of to make sense of both these bubbling, wonderful initiatives, sort of on the precipice of getting started, as well as these great ideas. So your thoughts about how to pull that together.
Thank you. So Wendy and Monique, 12 minutes, how we're going to reform the system. Do I got that?
That's right. No pressure. No pressure.
Okay. So yeah, Randy Morris, Alameda County Social Service Agency's Adult and Aging Services Department, and I've been in this position for 5 years, and there's really two things I'm going to talk about. And the first is I've had the fortune of being in the social service agency for 22 years. And in that time, I spent 17 years working in the child welfare department. Then when I applied to be a department director and got a call from HR to be one, it was not for the child welfare department, it was for this department. I took a deep breath and said yes. But at the time I took that job in 2011, this department managed not only the adult and aging services, but also this little program called Medi-Cal. And my primary assignment was to be the face of the social service agency to roll out the Affordable Care Act, expanded enrollment into Medi-Cal, which had me at the healthcare table quite a bit. And then also, since that time, I've had the adult and aging programs. Driving here, I was reflecting upon, I have actually sat at this exact table, I think 3 times in my tenure on the child welfare department talking about system reform and child welfare. Twice sitting at this table talking about the rollout of the Affordable Care Act and system reform, including sitting with Healthcare Service Agency and many partners about how we're going to get more people enrolled. And this is my second time, thanks to Wendy, with adult and aging. So the first of 2 things I wanted to talk about is, with a modicum of humility, having been part of system reform as a system administrator in 3 social service departments, there are some lessons learned that are irregardless of the content of the work that I have seen come together that I just wanted to share, which leads to the second I'm going to talk about, and that is a plan, yet another initiative that we are going to be rolling out, and I think how those lessons learned apply. So the lessons learned, I want to share 3. The first is, I'm going to call it initiative-itis. So I just want to put the elephant on the table. All 3 of those departments I've worked in and the partners, be it public partners or community partners, are under-resourced, underfunded, well-intended, big hearts, and don't have a lot of people power to do our day-to-day. Then reform comes. You got to do better by the people we serve. And then a little money comes, some foundation funding, some waivers come. Some of that money brings a person to help coordinate something, but then the initiatives start tripping over each other, and then here's where the rub is. All of those initiatives require all of us to go sit at the table of their hub, of their wheel, of their initiative. And before you know it, the efforts to better coordinate the very system you're trying to reform ends up with 2 or 3 not coordinated initiatives because they come from different funding streams and have everyone sitting at the same table and the initiatives aren't even coordinated. So having been through that, and now I can't be one of those managers looking up at somebody in my seat saying, why is this so confusing? I have to take responsibility to make sure that the initiative I'm going to talk about is coordinated, integrated, makes sense with all of my partners at the table so we don't end up in one of those initiative-itis modes. The second lesson learned I want to share is I want to, I didn't know this would be discussed in the first panel, but I thought it resonated with me tremendously, the talk about culture and language and not understanding each other's systems. As a complement to that, I wanted to say something that I admit is quite bureaucratic. And that is, for those of us in system administration roles, we spend a lot of time trying to tease out what is the role of federal government versus state government, county government, city municipalities. And it is complicated to do that even within one's own agency. So for me, I have programs that I've mentioned today: in-home supportive services, adult protective services. I hold the title of public guardian, the area agency on aging. Every one of those is funded by different funding streams from the federal and state government with different regulations. So even within my responsibilities in my silo, it's hard to understand this. Then you talk to all of my partners at the table, and then you get to the community providers, and then, oh my gosh, we're talking about consumers who none of this makes any sense, and they shouldn't have to understand this stuff. So in addition to talking language, I have found that in these initiatives, as a level set, it's so important to just help not only define the language, but help define jurisdictions. Because sometimes you spend too much time thinking, for example, a city or a county can fix something that can only be fixed by an act of Congress. So then you organize your effort to go to Congress as a team, and then you focus on things that the county can work on, like a board of supervisor action. So that's a second lesson learned, and I think it resonates quite a bit with the aging field. It's quite fragmented, quite complicated to understand. And then the third is, I want to key off of a question that was asked of the first panel, like, it sounds so medical. So let me go my version of old school and talk touchy-feely social work, because my training is in social work. An extension of learning jurisdiction and trying to figure out what's in local control and what's not in our control. The one thing we have complete and total control over each other as we're trying to reform systems and work together, and again, I apologize for the touchy-feely here, but it's how we treat each other and how we listen to each other. The initiatives I had the opportunity to participate in both child welfare and the roll-up from 2011 to 2014 and the hot mess from 2014 to 15 of thousands and thousands of cases backlogged in Medi-Cal. There were tables where the local people were working very well together, talking to each other, listening to each other, and trying to figure out how to work together to do something about it. And there were tables where it was nothing but finger pointing and anger. I'm not trying to minimize that particularly people who don't have the authority or power to get the system to fix shouldn't be angry. I think we have a high responsibility of people who are system administrators in big systems who bring a lot of resources to the table, but it really is in our control as we get ready to take the next 2, 3, 4 years together, whether or not we really commit to listening and working together. And absent that, I think there's a tremendous amount of inefficiency and time wasted at the local level dealing with finger pointing. So those are my 3 lessons learned that I will be thinking of as I think about this thing. Now I have 5 minutes to talk about. We are going to fix the system in Alameda County. So the background. There is an initiative underway. It's very public. It's been in front of health and social service committees of the board. You can look at the videos of it. I've been presenting a few times. But this is what happened. In about 2014 calendar budget year discussions at the Board of Supervisors, every year you go through budget discussions. The very big healthcare service agency presents first, talks about its budget, talks about its initiative, shares its pride of its work it's doing, and then the big social service agency gets up. So the healthcare director and then my boss, the social service director. And during both of those presentations, one of the board members, Supervisor Nate Miley, who's a big champion for elders and seniors, said to the healthcare director, "What are you going to do about seniors?" The very articulate former healthcare director, who I have never seen fumbled his words and said basically we need to do more and better. My director, who is very succinct and smart and competent, fumbled a bit too. That led to a directive. There's a lot of pride in this county of having coordinated work cross systems in the fields of poverty, homelessness, children and families. We have fallen short in coordinating, collaborating, and talking to each other in the field of aging. So we got a directive. That directive led to, and I don't got time to go through all of this, but it so happened to be that at the time, one of the programs administered in my department, the Area Agency on Aging, which if you don't know briefly, 30-second digression, in the 60s, right at the same time Medicare and Medicaid was created, something called the Older Americans Act was passed, which mandated that local jurisdictions would develop plans for seniors. And quite competently, quite capably, our Area Agency on Aging has been developing a plan for seniors. It's underfunded, it's very limited, the money is dramatically short of need, and remarkable that neither the Healthcare Service Agency director nor my boss in response to the board said, yes, we have a plan for seniors, you approve it every 4 years. But the elephant on the table, it's a plan sort of limited within the Area Agency on Aging, and it's not cross-system. So we chose to implement that directive at the time the area agency plan was being developed, and we did a couple things we've never done before. Number one, 2 public systems were brought to the table. Healthcare Service Agency under the directive. So Healthcare Service Agency, Public Health and Behavioral Health in particular, were at that planning table with us. In addition, shout out to my partner sitting in front, who I won't out by name, the Community Development Agency in Housing volunteered to be a public agency at the table because of the critical importance of dealing with housing as it relates to everything we're discussing. And then the second part of it was we actually created a committee and a forum that was public, Brown Act governed, and had community partners. Wendy was on it, advocates, CBOs, to really go through a plan. So for the first time ever, we developed that plan. That plan missed a key partner, which Healthcare Service Agency has identified, and that is, though it had public health and behavioral health, to the point of this discussion today, it did not pull in the healthcare safety net. There are two people sitting to my left who know something about that. So the big public hospital and its systems and the big local managed care plan are huge critical pieces of the Healthcare Service Agency, and we are missing a big piece of the puzzle if we don't include them. So going forward, we are about to go to the Board of Supervisors in January to bring forward what the proposal is to move forward all the work that played out in the year and a half to develop that plan, and you can go on the website and read it. I don't got time to, or maybe in question and answer we can go through some of the details. But what it is we have to be a village. We can't be the AAA or the social service agency or just try to make IHSS get to homeless people better. It can't just be the medical model discussion. It can't just be public. It can't just be CBOs. It's got to be a whole village. And to do that, this board, and I give them credit for that, has stated over and over, the voting public is fickle, and that was before the presidential election. They want to codify this in an ordinance, make it public and transparent, make it a Brown Act governed council that actually has seats but can always invite any member of the public. The minutes have to be posted, so it's very transparent and inclusive, where we sit together for the future and we figure out what we're going to do to implement the goals of that plan. It's going to be a lot of work, and to the lessons learned, it's going to take a lot of effort on our part to make sure we are value added. We do not cut the hub of the wheel, that we're the epicenter, but we coordinate, collaborate with all these other activities that don't require everybody to come to our table. So we got a lot of work to work on that, but this is the end of my presentation, a couple of the highlights. During that planning process, for the first time ever, we looked at data across all the systems. We didn't just look at the social service data or the results of surveys from seniors. We looked at actual data from our programs and healthcare programs and started bumping them together and broke them down by cities. When we started to see the story of seniors by cities, by language, by ethnicity, we did a better job. We have to institute a process to make sure that we do that ongoing, recurring, it's available to everybody, and we plan around that. So that's going to be part of what this council's charge is, to make sure to do that. Second, in our own backyard of Alameda County, we have a much more progressive and coordinated effort in the field of advocacy and legislation as it relates to kids and poverty issues. We have forums where we work together and we bring federal and state legislation and we bring advocacy as a team together in advance. And in our aging systems, our advocacy and legislative efforts tend to be fragmented in our silos, not organized. And in the last year, we have just got to the point where we get last minute, 11th hour, will you co-sign this thing, but it's never in advance. So we want to have this table be a place where we can start to more proactively and better coordinate. And then the last is, and you could take an hour and have a whole forum on this, there is this effort from the World Health Organization called age-friendly communities, to try to start thinking about how to have our communities really at the grassroots level. We have City of Berkeley here and Fremont here, who both have foundation-funded efforts to do that. We do not want to control or take over, but we want to be partner and invited to, and think about how we can take advantage of these efforts as part of this council, and think about how to bring them throughout the county and in the unincorporated. So lots of work to do, very excited about it. And again, I think the positive note I want to end on is I think the planning effort, and those in the room who are on that committee, we have a great start on that issue of working well together. So we have got a good start, but a lot of work to do.
Great. Well, I think, Scott, you did indeed pull it all together, so thank you so much. It was a wonderful way to just really understand and put that jigsaw puzzle together of how things can possibly fit. So all of you, thank you all so much. I'm going to encourage all of you, this is a good time now to write questions down, and then we have a few people who will pick those up. I'm going to start with some questions for our panelists. And let me just start right with you, Nancy, and maybe really sort of threading from what Randy just said. We have these initiatives, and I had asked in particular for Scott to clarify a little bit between the whole person care and health home. And as you look at these various county initiatives and the Medi-Cal managed care initiatives, what do you anticipate as both some viable and practical sort of barriers and solutions to resolving these barriers for working together. And it may be that you just follow suit there, or some other ideas to add to what Randy said. Go ahead.
Well, so I knew this question was coming. So I think that there are three, well, first of all, I want to say I'm hoping that you all will actually let us know your own thoughts about this question. What are our barriers for working together? But the three that I wanted to highlight are just the very practical issues around data sharing, the fact that our funding, and this is something that Randy mentioned, our funding tends to be siloed. And the third is, again, I think we've all touched on it, is organizational culture. So in terms of data sharing, we have to come together around agreements, and we have to come together around consent and balancing the very important concerns and considerations around privacy with the concerns around supporting collaboration. And really, there are creative solutions to these things. It's been done in other communities. So I think building that data sharing system that's going to enable us to communicate well. In terms of the siloed funding, I think it's largely a leadership issue. And again, like really what Randy was just saying, people should not need to know the alphabet soup of government in order to access services. We should be able to figure that out and present a seamless way for people to access care. And we need to, at a leadership level, make that a priority. And I wanted to call out that the Alliance and Alameda Health System and CHCN and our Healthcare Services Agency have been working to do that together for about a year, a little more than a year, and making that a priority and putting the resources into it is really critical. And then, I guess we've talked a lot already about organizational culture, but I think one of the things that we've built into whole person care is resources around developing common language and understanding each other, including, and I wrote that down, jurisdictions. That is a really good point. Cross-training, identifying common metrics, identifying projects where we need to work together, and using data to actually measure whether we've succeeded. Those are sort of my thoughts.
So what I'd like to do is just ask a few more questions rather of our panelists, and then these questions are terrific. They're really awesome from all of you, so I want to try to get to that. Next, Dr. Landau, you've had the benefit of not only seeing the big systems perspective, but you're really ground zero in terms of a practitioner and seeing people in front of you day to day. Thinking back to Dr. Kuchel's presentation, and thinking about all the system change from your perspective, what do you see needs to happen? Is it very similar from the initiative overview that we just heard from Nancy, or from your kind of real hands-on interaction with people? Is this viable and practical?
Is this on? Okay. I think it's essential. I think that we can't take good care of people, and we can't have an outcome where people thrive and do well unless we work together. And communication, I really do believe, is absolutely essential for good geriatric care. And I could tell you a million stories where the breakdown in one little place between a hospital and a nursing home can produce terrible outcome, or a patient going home and no one talks to the family. I mean, there are a million different places where that happens. And case by case, if you look at things, if you don't have an integrated and organized system, you can't prevent these things from happening. And the research on care management shows incredible cost savings. At geriatrics, there's a huge literature from like 30 years ago on care management in elders. In fact, there was a social HMO2, which was an attempt to try to integrate non-medical reimbursement from Medicare to take care of people on all these levels. So that I think it's essential, and I think that all the things that Randy talked about are critical for us to work together, because no one system can do it all, because people are never in just one system, perhaps except for with Kaiser. And so I think that if we don't do it, we're going to be in trouble.
So, and that's actually turning to you, Randy. This is a nice segue to you, and I'd like to add something from the audience. Your question was really the power of change from a community-based organization perspective, and we heard about that with our panelists in the first panel. And this individual also asked about sort of looking at community organizations and how you can tap that power of change, and they will add about consumers. Can you articulate in your response a little bit about where community partners who are actual consumers can help sort of facilitate that change, really pull that lever?
Sure. I'm thinking of two ways I want to answer that. Okay. The first is, and this gets back to education and jurisdiction. I think a lot of people aren't aware, I wasn't until I became management in social services, and back to regulations. Many state and federal regulations mandate that social service systems deliver their service through government employees. And so it's not a choice locally that we have our IHSS program, our APS program, or our public guardian program run by county employees. And I just say that as a preamble to say, I think one of two ways I want to answer this is, always trying to figure out what's the silver lining in the crazy that just happened on November 7th. It might be that the future is, there's no way our system can pull the entire rug out from vulnerable people and seniors, but it might be in the era of anti-government sentiment that some of those regulations get shifted and more of these services get shifted to community. And I'll give you one example, and Scott, pay attention because you know this. The IHSS program, which is a beast, it's a $440 million budget item in our agency, $440 million. And by the way, $400 million of that is the wages and benefits that pay the providers who provide the in-home care to our 24,000 clients. It's a huge system. It's mandated to be delivered by a county government. There is this thing called the Coordinated Care Initiative, which is legislation in California, which talks about bundling the IHSS program under the umbrella of, you got this, Scott? Managed care. The Legislative Analyst's Office came out a few years ago and said, part of California's initiative, maybe you should pull the IHSS program out of government and let managed care plans be able to do it through community organizations. So, I didn't get in this job because I want to build an empire. I want to get services out to people. So I think that today we have to look at CBOs because they're a lot of times closer to what's happening in the nooks and crannies where some of the hardest problems are and the biggest gaps are. But looking forward, it's going to be an era where these questions are going to be challenged about why things are run through public systems. So for both reasons, I think all the more reason we need to keep talking and thinking through together so we can maybe together be talking in Sacramento, D.C. about what the future should look like.
And going back to this new council, I clearly will have consumer positions available, so there's an opportunity for people to participate in that way?
Yeah, and I'm sorry I did the consumer thing. So we have a mandate on the in-home supportive services program by state statute. There's a public authority, which my mandate has a 50% consumer-run board, and if anyone in the audience wants to raise her hand to say she happens to be the chair of and jams me up all the time, including in a meeting yesterday. We, by mandate, have a consumer, which is both providers and consumers. But I do want to say, my boss, who grew up in the foster care system professionally with me, we did not have a mandate in child welfare to have a consumer voice, and we created a foster youth board. We created a parent board of successfully reunified families to inform what we do in the foster care system. Our agency is very committed to figuring out ways to better engage consumers. It's complicated, travel, mobility, et cetera, but it's something we need to keep an eye on.
Well, Scott, I'm going to conclude with a question for you, and then we're going to actually just address audience questions for the remainder of the time. And actually, Randy sort of highlighted that this is something that may really impact many of the programs and services, and at least the implementation of the initiatives, which is the recent election and what people are thinking about in terms of the horizon. So from your perspective, as a Medi-Cal managed care organization, and as you look at your members and you look at the mandate, really marching orders from your payer sources and CMS and Medi-Cal and so forth, what do you imagine will happen from the initiatives that we've talked about today? As you sort of play out in your mind what potentially could alter the pathway as we try to meet the needs of individuals who are older adults in this community? It's a short question. Just 2 minutes, no.
Yeah, I too had this question in advance, and as I looked into it more and more and really started thinking about it, so some ideas came to mind, and I'll share those with you. And I know if we went around the room with this question, we'd also get some other ideas, other great perspectives. But I'll share with you just in looking at, and I'm looking at it from probably a higher level around what is the underpinnings for a lot of these programs vis-a-vis the waivers that have been approved, and most notably the Medi-Cal 2020 waiver, the second part of the 1115, that hinges on and supports whole person care and Medi-Cal as a whole. And so ACA filled some of the Medicaid gaps that were there. But we need to move ahead. There's a lot we don't know right now around what the administration is going to do. But what we do know is that the care is needed. The patients don't change. We got to figure out solutions locally, work with our state leaders in new ways. And I think even at a community level, working and thinking differently. Hence, the opportunity of these programs is everything moves forward. In fact, I think it even gives us more energy to push ahead even more aggressively on creating some new ways, because one of the things I think we all knew and seen was payment reform, system reform as a whole was coming and is already here. So these are things we would be dealing with, issues we'd be dealing with anyways, and we'll get through those. In the Medi-Cal program, though, in terms of impact, and I could go on for a while here, but there are 3 areas to consider, and we've seen it back, if you go back to 2009 when adjustments were made to Medi-Cal benefits, and we saw some of the results of that. And you look and you read about block grants and per capita allotments and these payment reform mechanisms, eligibility, benefits, and provider rates. Those are the 3 areas that I think about of change. And areas, quite frankly, working with my trade associations and all our trade associations as a whole is linking together to get the voice out around the impact of these changes at an Alameda level. And it'll be at a state level and ultimately at a national. But I think a great time is coming where it's gonna cause us to draw together even closer. And so with that, I'll stop, because again, I could keep going on other areas, but the invitation, I think, is there again for us to be talking more about how do we treat what changes are coming in the Medi-Cal program, which ultimately supports a lot of these initiatives we're talking about here today.
So it's really coming together. We're hearing this as a repeated theme, and that's really important. Yeah. We're going to get down to a little bit of a granular level, and I'm going to start with you, Nancy, but it also was a question asked of you, Scott, which is about hunger. And we heard from Dr. Kushel about food security. And members of the audience both asked, first from the Whole Person Care Pilot, your approach to addressing the issue of hunger. And then it was also addressed in terms of the health plan. So I think an important question for both of you. So maybe Nancy first, or?
Yeah, sure. And actually, I think Randy might be even more appropriately the person to talk to. But, our goal is to create a framework to enable the people who do the care management to work more effectively together. And so that model that we need to elaborate and agree on needs to include the social determinants of health. Housing is a huge issue that we are really focused on in whole person care, but that doesn't mean that the other needs are not absolutely essential. So I know, for instance, and Randy could say more about this, that the community health center network clinics are engaged in an effort to enroll people in CalFresh. And as we design our care coordination system, we need to make sure that the care coordination system we are designing links those, food and also other needs together. So we aren't focusing on one versus another, but focusing on creating a framework that's going to enable us all to work on all of those needs better.
Randy, I don't know if you had a comment, and then maybe Scott could answer it from the health plan's perspective.
Thanks for outing me. I'm ready. Okay. I feel like I hear Wendy say this all the time, so Wendy, I'm going to channel you. And it hasn't been mentioned today, but it's worth naming, and back to this jurisdiction issue. Many of the, and this gets to CalFresh, many of the programs administered by social service safety net issues are means tested, which means you have to be so flippin' poor to be eligible that you have this three worlds. You've got people who actually are eligible for things like Medi-Cal and CalFresh, CalWorks. You got people who by chance are up in that upper echelon who have enough money to survive, and you have this growing sort of middle. So I just want to say that as a preface too, before getting too excited about all our great work in CalFresh and the work we have to do, that doesn't dent the issue of the people who are above the federal poverty levels. And back to jurisdiction, that's federal poverty level. They create those levels. We don't. And you know this thing called the Elder Economic Index, it's about 4 times higher than that to actually survive as an elder. But that said, California has one of the lowest, I think it's the lowest penetration rate in the United States for seniors who are eligible for SNAP, federal, CalFresh California, being enrolled. So a natural place to talk to them is this county. I had nothing to do with it. Healthcare, the Alliance, the FQHCs in the audience have done amazing work enrolling people in Medi-Cal and Health Pack, a very robust indigent care program. Those people are likely eligible for CalFresh. It's not an exact overlap. And so we are all underwater in the Affordable Care Act rollout, but now that we've come up for air, there are more efforts to make sure that when people are touching the lives in the community to help them be on or enroll in Medi-Cal to concurrently, and we also have the food bank here. We have another great partner with our local food bank doing lots of work to get more seniors enrolled in CalFresh. So great news, but let's also name that doesn't get to the people who are above those poverty level means tests.
So
It's also better.
right. So, and Scott, maybe you can answer it from the health plan. Thank you, Randy. Sort of food and providing food to members.
Well, I think organizationally, I think we all have different areas of responsibility, and this is where whole person care, some of these other initiatives that are coming into Alameda County and some that we're starting will transcend across what I'm responsible for versus county versus another agency, really stepping above that and talking about how do we come up with some solutions for us to work differently together to make sure that the nutrition's happening, to make sure that the food is getting out there. Because I know with my members, there's a significant portion there that are lacking food and proper nutrition. We know that. So how do we bridge that together?
Well, and it just becomes even more paramount, actually. I don't know if I can say that syntactically, but because of changes potentially under our new administration, we're not really sure. So we've got these needs, and as you said, really pulling everyone together, Scott, is going to be critical. Nancy, let me go back to you under the whole person care. We have several questions, a couple of things, and maybe I could give them at least in a bunch here. So how do you anticipate getting workers on the ground, boots on the ground, as the question was asked here, to begin to work with our vulnerable communities served under the whole person care pilot? And really maybe going hand in glove with that, another question which I think is very interesting is we look at those individuals who may be using the emergency room quite often, those who are identified possibly as high utilizers, but what about folks who may still be vulnerable and isolated, maybe not getting in there so often? Are they potentially going to be eligible? So one is, how do you really sort of engineer this effort with all your community partners, getting people out into the communities to engage people? And then what about some of those individuals who may not be quite fitting the definition?
Okay. So let's see. In terms of workers on the ground, I guess I'm going to assume that means case managers, people providing direct services. So I want to say again that this is primarily focused on infrastructure. So a big piece of the work, one big piece of the work is an IT and data exchange system, which will affect, as we get it off the ground, will affect people who are doing that work throughout the system. To the extent that we have new money for services, this is a place where we are going to be partnering with the Alliance and also with our housing, healthcare and housing people. We didn't get into this in the presentation because it gets kind of complicated, but we are, with the encouragement of the state and the feds, it's going to be a different model of delivering the services, where we are going to be paying on a per member per month basis. So basically, rather than, like, for the most part, in terms of the care management services that are new, rather than giving, you know, an agency, whatever, $50,000 to hire a case manager, it's going to be on a member, like a number of people that you are serving with a basic set of services each month. And we're going to be working together with the Alliance to develop, you know, the details of what that looks like. In terms of the question, and so we're going to be working together to, as part of the pilot that Scott was talking about earlier, to start small. It's going to be about learning how to do this well, starting small, and process improvement to get it right, test it, measure it, and expand it. So it's not going to be like a big flood of money all quick, I'm just going to say. Okay. Secondly, but we will be engaging with people on designing that. The other question, this program is targeted toward people who are high users. We actually stretched that definition about as far as we could because we know that there's a lot of people who really aren't using the system, and that's the problem. They're going to become expensive. From the Medi-Cal point of view, I think where they're trying to save money, they're trying to demonstrate that with these services we're going to save money. So that means that's why it came from the point of view of we're looking for people who are already expensive. So basically, we tried to define it as broadly as we could, given, again, I can talk in more detail about what that means, but if somebody has had a touch, an experience in the criminal justice system and an experience in the mental health system, they're going to count. If they've had 3 physical emergency department visits and they've had an experience in substance use, a service in substance use, they're going to count. So we tried to define this really as people who are touching more than one system, crisis system, but not necessarily the most expensive people, because we're trying to get it so they aren't the most expensive people.
This final question is for Dr. Landau. You had mentioned with your consultative and evaluative service, Institute on Aging, that you had those 3 prongs, and then we heard also that you also mentioned that there is this great need to really train primary care providers. So could you just chat very briefly about any effort or any thoughts you have about really engaging and educating some of these terrific primary care providers who are already out there? Lifelong Medical has a series of clinics, and some of them are geriatric trained, but some are not. And your thoughts about that as a leader?
So one of the roles I have is also working with the Institute on Aging and Geriatric Education Centers. And they have a lot of wonderful educational modules that I know have gone into many of the community-based clinics and done some training. So one of the things that we conceptualized in our Institute on Aging was that we would do some training vis-a-vis the patients that we see with the practitioners, but also organize some training along particularly these geriatric syndromes in Alameda County, probably starting within our own system at our own clinics, but can be expanded. One of the issues is that I think people have mentioned is time. So right now, I'm the only full-time geriatrician at Alameda Health System. And so all these things that I'm mentioning, I'm doing. So we need to sort of build the capacity to do education. And one of them is hopefully finding people in clinics that we can sort of train the trainer model. And I would be delighted to talk to anybody about doing that. We do training. UCSF Geriatric Education Center also will come to and do training. And there's a mandate from, I'm not sure which agency pays for that, but, and they do a fabulous job. So I think we need to, as a community, do a coordinated effort in education as well, because clearly one system can't do it all, but I think we could have even a consortium of education, because it's not just training clinicians. Like, one of the things I would love to do is train IHSS workers in how to understand when somebody's sick, so they would know what to do in terms of being advocates for their clients. So there are a lot of opportunities.
Terrific. I'd like to just conclude the panel. We're getting close to the lunch hour. I'd like to thank all of the panelists. That was terrific. Thank you so much. And do you have any questions? Thank you very much.
Excuse me, before you finish, I'd like to ask you a question, which is why nobody on the panel has addressed the true obstacle to reform in Alameda County. Here we go. Okay. My name is Matt Berry. I'm a reporter. I write specifically on aging issues. I've written about aging for about 6 years. I see what works and I see what doesn't work. Luckily, I've written about Karen Gripsit. She is an amazing leader in Fremont County. She's a true visionary. We have somebody in Los Angeles County, Laura Trejo, who now is supported by the mayor of Los Angeles, Eric Garcetti, a true believer in reform. We're going to make changes down there. On September 26th, there was a joint session of the Board of Supervisors here between Health and Social Services. And Supervisor Miley requested an update on the changes in the plans and aging. Mr. Morris provided 4 bullet points. 4 bullet points. Even I was watching. When I saw this, I was embarrassed. Visionaries make changes. Today, Mr. Morris is here giving mostly excuses for why he can't do a good job in this county.
So Matt,
The obstacles, let me just finish, please. This is important. I think you and I have spoken. I've spoken to Rebecca Gephardt. I'm talking to Supervisor Miley. Somebody needs to say this, because nobody else in this place can say this. Because you guys, everybody here has somebody that they have, a boss, has somebody that they. Luckily, I'm a freelance writer. I don't have anybody that I need to. So when Supervisor Miley says, where's the meeting? Supervisor Chan said, I don't get it when I see this thing. We've been at this for a year and a half.
So Matt, I think I'll step in and answer for Randy, and actually for all of us.
I think Randy should respond.
Yeah, but you know what? I appreciate journalists stepping up, because I think journalists are going to have to step up more in the future. But I've been a part of the process, and what I can say is that the update on the plan was that the plan was going to become an ordinance. I mean, there are steps to take in order to establish a new body to move aging systems forward in Alameda County. There isn't such a thing there. If we rely on individual champions to move this forward, one of us could get hit by a truck tomorrow and the whole thing would go poof. We've got to get an ordinance established so that it is ingrained in the operations of the county. And that's what we're working towards. And yes, it takes a god-awful amount of time. But I do think that it's moving forward. And one of the things that I was going to say about the 2 panels that we've had today and our keynote speaker is that in this county, we already have so many of the right people at the table working together. And when I talk to people in other counties across the state, they're still in their silos, and someone in the health system doesn't even know who Randy's compatriot in the other silo is. They've never talked. So it's a massive ship that has to be turned around when you're talking about county systems, and all of the community-based organizations that are nimble and ready to move on a dime, because that's what they've all had to do, they're really impatient about this. But we've got to do it together, and we can't divide each other by arguing too much. We need to argue productively. So that's what I'll say, and I would encourage you to participate in any of the discussion cafes this afternoon. But I'm going to have to move us on because it is, it sounds like you are all on the road to being informed, motivated, inspired, and alarmed in equal parts, right? And I think Matt's more alarmed than a lot of us, but I think that what we've seen is this collaboration is a process, and we're going to move that process a little bit incrementally forward now with our discussion cafes. These are small group discussions, and they're designed to help you just chew on what you've heard and synthesize what you've heard, but they're also designed for you, all of you, every single one of you, to give us feedback, so that we can capture it. And we're going to put it up on the community wall, and we're going to incorporate it into the proceedings, and the Senior Services Coalition is going to use it when we're talking to policymakers and when we're moving these things forward. So I really want you to know that we're listening to you today, and that is what the purpose of the working lunch that I'm going to assign you to is all about. On the last page of your program, you'll find a description of the 6 discussion topics, and you'll want to choose one, okay? But before you do that, and before you grab lunch and move to your discussion groups, I want to tell you a little bit about how it's going to work. So each of the numbered tables in the room has been assigned one of these 6 topics. You'll see on the screen the table numbers that correspond to the different topics. And each table is going to receive a discussion guide, okay, and a few conversation-starting questions that are specific to that topic. You'll want to appoint a facilitator if you don't already have one. Some of the tables do have facilitators, and they'll raise their hands. I think that you'll have panelists from both of the panels sitting with you, and you may ask them to be facilitators, or you may want them to simply be people who are part of the discussion. So just think about that. And you'll also want to appoint a note taker, because you'll want to document your takeaways, and we'll post them on the community wall. The discussion cafes will take about 35 to 40 minutes, but you really have an hour for lunch. And so, spend the time wisely and productively, having conversations, capture the takeaways. Don't make judgments about what takeaway is important. Capture it, put it on the wall, and we'll listen. So take 10 or 15 minutes to find your table, grab lunch, settle down for some good conversation. And when you're getting close to time, we'll let you know. And please ask me questions. Danielle, you can ask questions. Jordan, you can ask questions. And we'll be circulating. Thank you.
Thank you.
Sorry, I didn't mean you guys to stay up.
I know, we were all thrown a little bit.